Assalamu alaikum. This is Dr. Amna, and this is the presentation regarding malignant ovarian cyst. Like I have uploaded also the benign ovarian cyst. These are very important for the especially part two exam because they can give a scenario and they wanted to know whether you can identify the type of cyst on the history on the basis of history and examination and TVS findings. So as I have mentioned that in the ovary there are three structures: germ cell and stromal cell and epithelial cells. So the cancers can also be ovarian malignant cyst can also be categorized according to these things. So now we will start. So ovarian cancer is the second most common gynecological malignancy. The primary cause of death from gynecological cancer in the UK. These are also questions because they can give you a statement like which cancer is the leading cause and second most cause of the gynecological malignancy, and also what is the primary cause of death of gynecological cancer in the UK. It is the second most common but primary cause of death from gynecological cancer because this cancer has vague symptoms and they are not easily identified in early stage, and there are no screening definitive and good screening is not available for the ovarian cancer. So that's why the special patient which has which have history of genetic disease, genetic ovarian cancer in their family, like BRCA 1 and 2 family or Lynch syndrome. So these patients are specifically identified and they are offered risk-reducing surgeries to prevent the ovarian cancer, because this cancer is not having good prognosis because they are diagnosed at later stages. So screening has not been shown to be effective. Incidence of ovarian cancer, a lifetime risk of developing ovarian cancer in general population is 2%, 1 in 50. So these definitions, these incidences are important. The mean age of presentation is 64 years, more prevalent in high income countries. White women have the highest incidence at approximately 18 per 100,000, whereas Asian and Black women have a lower incidence at 12 per 100,000 for Asians and 9 per 100,000 for Black women. Ovarian cancer is rare in young women, and only 3% of ovarian cancer occur in patients under 35 years of age. So a very important point we have discussed in previous presentations, that most of the cyst and masses which are supposed to be ovarian in the start, when we investigate those, they turn out not to be ovarian. And also ovarian cancer is rare in young women. 3% of ovarian cancer occur in patients under 35 years of age. And it is now increasingly accepted that many ovarian cancer originate in the fallopian tube rather than in the ovarian surface epithelium as previously thought. So this point is very important because now they think that fallopian tube is responsible for most of the ovarian cancer. So how can we use it in our benefit? Like whenever we need to remove do the hysterectomy, so we will remove the tubes. Even there can be debate about whether you want to remove the ovary or not, but there is no debate about removal of the fallopian tube, because you once you remove the fallopian tube, there is less chances of developing ovarian cancer in that patient. Women with hereditary cancer present early with a mean age of diagnosis of 54 years. As in general population, this age is 64. And with the hereditary cancer, mean age of diagnosis is 54 years. Classification of ovarian cancer: primary ovarian cancers are epithelial 80%, sex cord stromal 10%, and germ cell 10%. The ovary is also common site for metastatic spread. So we can, whenever there are ovarian cancer, we can say primary cancers, metastatic cancer, and there are also unclassified cancers. So unclassified and these things are not to be explained much. So the main things are primary cancer and the metastatic cancer. And the primary cancer are 80% epithelial, 10% sex cord stromal, and germ cell 10%. So classification of malignant ovarian tumors. Here I will enumerate and then I will discuss in the next slides. So epithelial ovarian tumor, which are basically 80% of the malignant tumor, they are divided into high-grade serous and endometrioid, clear cell carcinoma, mucinous carcinoma, and low-grade serous, which are called as borderline. High-grade serous and the low-grade. Low-grade is called borderline. Then sex cord stromal tumors are the main tumors which produce hormones, and whenever these tumors are in the person, there is a risk of precocious puberty if it's a young child, and there can be also the risk of endometrial hyperplasia if it's a perimenopausal woman. When there is unopposed estrogen is coming from the granulosa cells tumors, then it will act on the endometrium, and there is hyperplasia and endometrial carcinoma. Sertoli Leydig cell tumor, and these are testosterone producing tumors, Sertoli Leydig cell, and gyandroblastoma. So then come the germ cell tumor are having dysgerminoma, endodermal sinus tumor, that are yolk sac tumors, and teratomas, and choriocarcinomas. Now, and the mixed also are the germ cell tumors. Then comes the metastatic, including Krukenberg tumors. Now we will discuss these tumors in slightly more detail. And these basically all things which I will explain now, these can come in as a part of part 2 exam, because they can make questions from these and they will give you multiple choices and you have to choose one. So approximately 10% of epithelial tumors are classified as borderline ovarian tumors. So we know that total primary tumors, among total primary tumors, there are 80% ovarian epithelial tumors, and among epithelial tumors, 10% are borderline ovarian tumors. So these tumors are well differentiated and have some features of malignancy, like nuclear pleomorphism, cellular atypia, but do not invade the basement membrane. This is the difference between borderline tumor and the high-grade serous tumors. Borderline ovarian tumors spread to other abdominopelvic structures like peritoneum and omentum, do not often recur following initial surgery. There's less recurrence in these type of cancers. Majority of the BOTS are serous tumors, and mucinous BOTS may arise from appendiceal carcinoma of low malignant potential and can be associated with the pseudomyxoma peritoniae. CA125 is a tumor marker for epithelial ovarian cancer, serous borderline ovarian tumor. Here is CA125. CA125 is is present in the can be raised in epithelial ovarian tumors. Whenever there is a serous tumor in the serous epithelial tumors or serous borderline ovarian tumors, this is CA125 is raised. If there is are mucinous ovarian tumors or borderline tumors which are mucinous in origin, there is another serum tumor marker we will discuss next slide. High-grade serous carcinoma account for around 75% of all epithelial ovarian cancers. So now total ovarian cancers, if we discuss like primary and metastatic, in the primary, there are 80% of epithelial. Among epithelial, there are 10% are low-grade serous carcinomas, and 75% are high-grade, and rest are the rest of the tumors. High-grade serous tumors are characterized histologically by a concentric ring of calcification known as psammoma bodies. So they will ask that there is a type of cancer on histology. They have seen psammoma bodies. So what type of cancer it can be? It can come in the part 1 exam, MRCG1 and MRCG2. And same with the FCPS. They can give it FCPS 1 and 2 written exam. Present with advanced disease involving the ovary, fallopian tube, and peritoneal surfaces. It is often impossible to establish the anatomical site of origin. 30% of high-grade pelvic serous cancers are associated with somatic or germline BRCA mutations, with implication for treatment, prognosis, and breast cancer risk. So I have discussed, I think in the previous presentation, that whenever patient, there can come the scenario in part 3 exam, the patient comes and says that I'm very worried because my mother has been diagnosed with ovarian cancer. So I'm worried whether I'm an increased risk of cancer or not. So we should ask what type of cancer she is having. If she is having stromal cell sex cord stromal tumor, or she's having germ cell tumor, these are not the hereditary tumors. So if it is epithelial tumors, then these runs in the family. So that's why we will investigate further, and we will send, if the mother is alive, we can send her for the to the genetic counselor and this patient, and then they can screen, they can diagnose their diagnostic testing and screening testing for the genetic conditions. Diagnostic testing is done on the patient. Like if on mother is investigated because she's having ovarian cancer, so we can see whether she's having BRCA or she's having Lynch. We can diagnose that specific gene in the mother, and then we will be sure that in the family members what gene we need to be tested. Instead of we this is more difficult and more costly if there is no patient is not present and patient has died, and we don't know exactly what type of gene she was having and which has been transferred to the family. So the most important thing is epithelial cancers are associated with the and among epithelial tumor, high grade pelvic serous cancers are associated with the somatic and germline BRCA mutations. Then CA1 to 5 is tumor marker for epithelial ovarian I have mentioned that for all serous tumors like high grade or low grade, like borderline tumor, CA1 to 5. Then comes these three cancers are I have discussed together: endometrioid, mucinous, and clear cell carcinoma. Endometrioid and clear cell carcinoma is associated with the endometriosis. This is also the question of part 1 exam, I remember. Mucinous and endometrial tumors are less common, together accounting for 10%, followed by clear cell carcinoma. Endometriosis associated ovarian cancers are usually of an endometrioid or clear cell histological subtype. CA19-9 is tumor marker for epithelial ovarian cancer, mucinous, borderline ovarian tumors. These are the, up till now I have discussed the epithelial tumors, and now we will discuss the sex cord stromal tumors. Though I have mentioned it, they can be arising as any cyst in the ovary which arise from sex cord. They can be from the theca cells and the granulosa cell, and also from the fibroblast. And fibroblast as does not produce hormones, so any benign cyst of the fibroblast or fibroma, they do not produce hormone, but they produce ascites, and they are associated with the Meigs syndrome. And here, sex cord stromal, these tumors account for approximately 10% of ovarian tumors, but almost 90% of all functional, that is hormone-producing tumors. They are tumors of low malignant potential with a good long-term prognosis. Most sex cord stromal tumors present as unilateral ovarian masses measuring up to 15 centimeters in diameter. Macroscopically, the tumor is often solid with areas of hemorrhage, and the cut surfaces may be yellow due to high levels of steroid production, because they are producing hormone, and hormones are obviously steroid. So they absorb more cholesterol and produce steroids. So that's why when you do the cut section, they are yellow. Now we will discuss the granulosa cell tumor. That previous slide was the general discussion about the germ cell tumor. Now we are talking specifically. Granulosa cell type are divided into adult type and juvenile type. In adult type, median ages, they're mostly granulosa cell tumors are of adult types. They're 95%, and median age is 50 to 54. Juvenile granulosa cell tumors usually present in those under 10 years of age, causing precocious puberty due to estrogen secretion. So this is very logical. In the adult, when there is increased estrogen, there is endometrial hyperplasia, endometrial carcinoma. In the juvenile granulosa tumor, there will be more estrogen, there is precocious puberty. And we know the precocious puberty is the having periods less than 8 years of age. Granulosa cell tumors are the most common subtype, accounting for over 70% of sex cord stromal tumor. Excess estrogen causes endometrial hyperplasia in the adult type and associated with endometrial carcinoma. Endometrial biopsy may be required. This all we have discussed in endometrial hyperplasia guideline. Now we know what is the, how can we diagnose endometrial hyperplasia, how can we do the biopsy, and how can we move further. Granulosa cell tumors produces inhibin, which can be used for follow-up. So this is the tumor marker for granulosa cell. So they can ask granulosa cell, what is the tumor marker for granulosa cell and what type of hormone it produces. So it can produce estrogen, and granulosa cell tumor produce inhibin, which can be used for follow-up surveillance. Levels often rise prior to clinical detection of recurrence. So when you keep on checking for the tumor marker, and when it comes normal and then it suddenly increase, it means it's about to recur. And Sertoli Leydig cell tumors, these are basically androgen producing tumors, and produce androgen in over 50% of cases. So patient present with a pelvic mass and a signs of viralization. So this is the woman which will look like the patient of polycystic ovarian disease, like hirsutism, horsewise, and absent periods. There are more uh, testosterone is in the patient. Common symptoms are amenorrhea, deep voice, and hirsutism. Occasionally, this group of tumors produce estrogen and rarely renin, causing hypertension. So now comes the malignant cell tumor. In the malignant germ cell tumor. So in the benign type, we have discussed the mature dermoid cyst. So in the malignant form, occur mainly in young women and account for approximately 10% of ovarian tumors. They are derived from primordial germ cells within ovary, and because of this may contain any cell type. The emphasis of management is based mainly on fertility preserving surgery and chemotherapy. So we will try our best to save the fertility. But now, as we know, with the further development, we know nowadays the um, how to do the fertility preserving techniques, like we can store ovum and like embryos, and then we can reimplant in the woman. So these techniques are very good and very promising in these type of patient who are having tumors and they need chemotherapy. So we do not want to wait for iatrogenic menopause in these patients, so that they cannot have their families in future. So fertility preserving techniques are very good and promising for these type of patient. 10% of patient acutely present 10% present acutely with torsion or hemorrhage, and due to the age incidence, some present during pregnancy. 70% of germ cell tumors are stage 1. Spread is by lymphatic or blood. So further, these are the germ cells of dysgerminoma, endodermal sinus yolk sac tumor. Dysgerminoma account for 50% of all germ cell tumors. They are bilateral in 20% of cases. The dysgerminomas cells these are identical to the seminomas in the testes. So these are if you will they will give you that patient is having cyst, and on the histologies there are seminoma type cell. So these are dysgerminomas. These are bilateral in 20% of cases. Occasionally secrete beta SCG, human chorionic gonadotrophin. And then comes the endodermal yolk sac tumor. Yolk sac tumors produce alpha fetoprotein. So you can memorize in many ways, like yolk sac, some say sac, SACA is the central A is for the alpha fetoprotein. You can memorize by these things. Second most common germ cell tumor, accounting for 15% of the total. They are rarely bilateral, secrete alpha fetoprotein. They present with a large solid mass that often cause acute symptom with torsion or rupture. Spread of endodermal sinus tumor is late event and is usually to the lungs. Then further types of germ cell tumors are immature teratomas, and its benign form is mature teratomas, that is dermoid cyst. And in the dermoid cyst, it also carries the less than 2% risk of turning into malignant form. And these are immature teratomas are the malignant form of germ cell tumors. Account for 15 to 20% of malignant germ cell tumor and is about 1% of all teratomas. They are classified as mature or immature, depending on the grading of neural tissue present. About 1/3 of teratoma secrete alpha fetoproteins. Occasionally, there can be malignant transformation within a mature teratoma. The most common cell type to transform is epithelial. Usually, squamous cell carcinoma will be associated with the mature teratomas. Then non-gestational choriocarcinoma, these are different from the gestational choriocarcinomas, because non-gestational are not having good prognosis as compared to gestational choriocarcinoma. Or these are in the gestational choriocarcinoma, we know we don't need surgery much. We need they're responsive to chemotherapy, but these are not good responding to chemotherapy. These are rare, usually present in younger women with irregular bleeding and secrete very high level of HCG and may cause irregular bleeding, may present with precocious puberty. And these are the all type I have mentioned now in the previous presentation, benign ovarian cyst types, and these are malignant ovarian cyst. So there are few risk factors in the ovarian cancer that can decrease the risk of ovarian cancer or can increase the risk of ovarian cancer. So whenever a patient comes with a family history of ovarian cancer, or in generally the women who are having increased risk factors, we need to tell all the risk factors to the woman which are protective or which can increase the risk of cancer. So that because as we know, this cancer is not having very good screening techniques, and it's not identified at early stage. So decreased risk of ovarian cancer is in generally we know whenever there is more ovulation, more risk of ovarian cancer. The conditions which cause less ovulation, those are protective for ovarian cancer, like multiparity. If the patient has become pregnant for 5 times or 6 times, then in the almost 1 year, 5 years, including breastfeeding and in the pregnancy, she is protected for many years for the ovulation, from the ovulation. So she has ovulated less than nulliparous women. So multiparity is protected combined oral contraceptive pill because um, they stop the ovulation. So relative risk reduced by up to 50%. Tubal ligation, because with the tubal ligation, because they say whenever there is a tubal ligation or tubal remover, it is the protection for the ovarian cancer. Nowadays, there is another thing going on that like in the patients which are increased risk of cancer, they want to see whether if we remove the tubes early, and then we keep the ovary there, and they want to see after some time, they give more time to the patient to remove the ovary, because when we remove the ovary, then it will cause surgical menopause, so we will have to give the HRT, and HRT in turn increase the risk of cancers in the body. So that's why we want to avoid all these side effects. So that's why they are working on it, whether we can apply this technique that we can remove tubes earlier, and then we will wait for some time, some years, and then remove ovary. So they say tubal ligation and self-injectomy has a protective role for ovarian cancer. And then comes the hysterectomy. Increases for the hysterectomy, again, we remove there's areas around the ovary. We can cut down all these things. So ovaries are protected, because ovaries are, we need ovary whether the patient want to have family or not until the age of menopause, for the protective effect of bone and heart. And increased risk of ovarian cancer is in nulliparous, intrauterine device, endometriosis, cigarette smoking, mucinous tumors only, um, and hereditary predisposition, because with cigarette smoking, there's increased risk of mucinous tumors. Hereditary predisposition, for example, BRCA pathogenic variant and Lynch syndrome carriers, and obesity, because of the obesity, there's increased estrogen peripheral conversion of cholesterol to estrogen. So there's increased estrogen in the body. So this is all in the for the malignant ovarian cyst. Thank you so much.